Hello everyone, Drew Thompson speaking to you from the Division of Emergency Medicine Point-of-Care Ultrasound program here at Western University. Welcome to this installment of our Practical Point-of-Care Ultrasound series. The goal of this session is to review the scanning technique and proper archiving for the assessment of the female pelvis. The next screencast in this series will discuss the sonographic findings in first trimester pregnancies and define the necessary steps in confirming an early intrauterine pregnancy or IUP. A subsequent screencast will provide a review of some of the pearls, pitfalls, and clinical pathways that accompany this bedside study. And as always, please visit us at WesternSono.ca for all of our updated ultrasound resources. Let's begin with a common presentation seen every day in emergency departments across the country. You're working a night shift on a busy weekend, and your next patient to be seen is a 29-year-old female complaining of a subacute onset of crampy left lower quadrant pain earlier in the day. While the cramping has been steadily increasing in its intensity, she has also now noted that she is spotting over the last several hours. Despite your best efforts at questioning, the patient cannot reliably recall the details of her last menstrual period. At triage, her initial blood pressure is 100/60 with a heart rate of 105. This case presentation highlights the potential emergent differential diagnosis that we must consider as emergency physicians. Here we have a potentially pregnant female, and if she turns out to be, one must be concerned about the possibility of ectopic pregnancy. Or is this a miscarriage? Of course, she may not be pregnant. Is this the onset of her menstrual cycle? By now you should realize that not only is a qualitative beta HCG indicated, this is also the perfect time to reach for your bedside ultrasound unit. There are two main uses for point-of-care ultrasound of the female pelvis. In the obstetrical portion of the pelvic bedside scan, the main focus of this series of screencasts, we are most concerned with the assessment of any female of reproductive age presenting with abdominal pain, vaginal bleeding, presyncope or syncope. This tool is especially useful with a known positive beta HCG, but is also a valuable adjunct in assessing females with these complaints and a potentially positive beta HCG. There is no contraindication to putting the probe on the patient to gain more clinical information before lab tests return. As we will see, our plan will be to confidently find the female uterus and interrogate it for confirmatory findings of intrauterine pregnancy in patients in their known or presumed first trimester. This is the period of time most likely to present with a more sinister diagnosis of ectopic gestations. We also use this tool for a secondary goal, that being to determine the presence or absence of free fluid in the female pelvis. This is a very important component of the FAST exam when assessing for potential intra-abdominal hemorrhage following trauma. The evaluation of free fluid may also provide valuable information when assessing our pregnant population, especially if there's concern for an ectopic pregnancy that may have ruptured. Now that we know that we will be focusing our attention on the female pelvis, let's review the pertinent anatomy and techniques in generating our point-of-care images. Sonography of the pelvis can be approached with two different techniques, each of which includes two different planes of scanning. The first approach will be familiar to you from your experience in scanning the aorta. In the trans-abdominal assessment of the pelvis, we will use our familiar planes of scanning, longitudinal and transverse, to identify and interrogate our area of interest. The pelvic assessment may also include a new technique in your armamentarium, that of transvaginal or endocavitary scanning. This is also done in two planes, although as we will soon see, it is more appropriate to label these planes as sagittal and coronal. We will review both of these techniques with diagrams and images in just a moment, but first let's bring this back to familiar basics. As you will recall, there is a common approach that can be applied to scanning in all of the basic applications of point-of-care ultrasound. The anatomic landmarks are reminders of where to place the probe on the patient's body when beginning a study. The sonographic landmark is an identifiable structure on the screen that tells you that you're at the right location to begin looking for your area of interest. And of course, the area of interest is the target of the study, and the area you are looking to evaluate for positive or negative findings. As a simplified reminder, when you begin scanning, in basic applications the area of interest is always white, and it should be found before any interpretations are made about what you see on screen. When we apply this approach to the bedside female pelvic study, we see that our anatomic landmark is the symphysis. This will not be applicable to the transvaginal scan, as we will see shortly. Our sonographic landmark is the bladder, and our area of interest is the endometrial stripe, which will be white. In this case, the uterus is not really adequate to define our area of interest. Rather, we are specifically looking for the middle of the uterus, the location of the endometrial canal. It is here that we should be looking for our sonographic evidence of pregnancy. If you are sure to find the middle of the uterus before you even think of looking for these findings of pregnancy, you will always be safe. We cannot emphasize enough how distracting it can be to see a fetus on a screen. Without a careful, methodical approach, it'll be too easy to misidentify the obvious pregnancy as being a normal pregnancy, when it in fact is not in the center of the uterus. Find the white endometrial stripe first. As one of my mentors has always cautioned, don't get drawn to the dark side. As with all of our basic applications, this transabdominal assessment of the pelvis can be done with either the curvilinear or the phased array probe. Either of these probes can be selected from the Triple Connect system on all of our Sonosite units. As you begin your training, you may find the curvilinear probe easier to use. Many find the nature of this probe easier to grasp probe technique. As you gain confidence, the phased array probe is equally suitable for this study, with only a few minor adjustments required to optimize scanning. Once the probe is selected, we can set its initial depth to a mid-range, ideally 15 to 18 centimeters, to be sure we are seeing deep enough into the pelvic cavity, although the female pelvis is not as deep a structure as some of our other scans. As a reminder, the depth buttons are located here on the keyboard and will be shown here on the screen. So let's begin in the longitudinal plane and identify the important anatomic correlates that we will aim to identify on our ultrasound screen. Our anatomic landmark is here at the symphysis pubis, and this is where the probe is placed to begin the study. Note that the probe marker is oriented towards the patient's head. Next, we find our sonographic landmark, the bladder, which tells us our area of interest, the uterus, and more specifically its endometrial canal, should be in the immediate vicinity. This juxtaposition beside one another is crucial to be certain that you are in fact identifying the uterus, and when assessing for features of pregnancy, one must be sure your eyes are focused within the confines of the uterus before any other observations are made. Remember to look for the white first. Don't be drawn to the dark side. We can see that it is very important in this study to have a full bladder in the majority of patients. This space is usually occupied by bowel and causes scatter artifact. As such, this will make it very difficult to get a determinate study. As the bladder fills, the acoustic window allows us a better chance to see deeper into the pelvis. A few additional noteworthy observations on this diagram. Here we see the vaginal canal leading to the cervix. These are structures that we will see on our ultrasound images and are further convincing findings that one is in fact looking at the uterus. And finally, to harken back to our assessments for free fluid, we know that fluid will tend to collect here in the pouch of Douglas, or rectouterine pouch, and if substantial, may also be seen in the vesicouterine space. These areas should be assessed when performing all pelvic scans. So how will this appear on our ultrasound screen? We can see the structures we have identified are readily visible on this generated ultrasound image. The bladder is seen as an anechoic structure surrounded by a thick wall containing the fluid. Let's take a closer look. We also see that there is a solid density immediately adjacent to the bladder, satisfying our criteria that this is in fact the uterus. If further evidence is required, we can also follow the vaginal canal to the cervix, and we then see that the cervix and uterus are connected and adjacent to the bladder, thereby confirming our findings. We then turn our attention to the center of the uterus, marked here by our white area of interest, the endometrial stripe. It is here that we can now begin looking for our findings of intrauterine pregnancy with a slow sweep through the entire uterus. As mentioned on our last slide, we must also assess for free fluid, a regular anechoic fluid without containing borders. We're going to look in two locations, here and here. Let's take a look at a proper sweep of the longitudinal uterus. Here we see that we have positioned our area of interest in the center of the screen, and now we will pin the head of our probe to the skin and slowly sweep in one direction and then the other, being sure we have swept through the entire uterus, looking for our findings of pregnancy. Now that we have reviewed the important structures that you will identify on your pelvic scans, let's review a quick test of your screen orientation. When viewing this image, which area of the screen represents the patient's head? Recall that our probe marker is oriented towards the patient's head when we place our probe at the location of our anatomic landmark. How about the patient's posterior? In this scan, the patient's posterior is visualized in the far field. Please take a moment to be sure you understand these pertinent orientations. Once we have completed our longitudinal sweep, we will now also perform a similar sweep in a transverse plane. Again, we will place our probe immediately cephalad to the symphysis, this time with our probe marker pointing toward the patient's right. Again, a full bladder is key to maximizing the acoustic window. Admittedly, the bladder is a bit empty in this anatomic diagram, so let's fill it up a little bit. Now the beam will find a good window to allow assessment of the deeper structures in the pelvis. You can also see that keeping your probe at the symphysis will be sure to allow you the best possible window through the bladder. If you let your hand drift away from the symphysis, you may miss this opportunity to look through the bladder window, and you may lose your image to scatter. If you are having any difficulty in seeing the uterus as you are scanning, be sure to pull yourself back down to the symphysis to maximize your chances of using a better bladder window. The plane of our beam is now oriented 90 degrees from our previous longitudinal study, so we expect to see the uterus in some degree of cross-section on our ultrasound screen. Well, this is as good a time as any to remind you that the uterus is a very mobile structure. Its position will be highly dependent on how full the bladder is and vary quite a bit from female to female. The uterus may be anteverted, may be retroverted, or even pointing into one of the adnexal regions. Depending on the position of the uterus, the expected cross-sectional image on a transverse study may not be what you thought you were going to see. The nice thing about beginning your study in the longitudinal plane is that you can learn to predict what you might see on your transverse study. Certainly as you begin your training studies, you should always start in the longitudinal plane. So keeping this diagram in mind, how is this going to appear on your screen? Is this what you imagined? Well, let's start with orientation. Which side is the patient's right? When in doubt, look where your probe marker is. You oriented your probe at the patient's symphysis towards the patient's right, so this helps orient yourself on the screen. How about the patient's anterior? This is represented in the near field. The ultrasound beam hits the most anterior structures first, and this is in the near field of the image. Now let's identify the important structures. The sonographic landmark? Here, the bladder. The area of interest? This is the solid organ density of the uterus, immediately adjacent to the bladder. And of course, there's the ever important middle of the uterus, the endometrial canal, represented by the white endometrial stripe. When assessing for pregnancy, your eyes will be here as you perform your sweep. You found the white first, and you weren't drawn to any distracting forces from the dark side. And finally, you're going to assess for free fluid. Where will you be looking? The pouch of Douglas is here. The vesicouterine space is here. Both may show evidence of free fluid as volumes accumulate. Now that the area of interest is identified, we need to sweep through the uterus to see its entire length. Similar to previous studies, we pin our probe on the skin, again remembering to stay near the symphysis to maximize our bladder window, and we rock our probe into the pelvis and back to perform our sweep. A representative cross-section of two positions of our sweep might look something like these images shown on screen. Here are the corresponding ultrasound images of these positions. Note that there's an important distinction here in the shape and the structure in our far field. The uterus should be round in appearance, as we see in this first ultrasound image. When we scan into the pelvis, we see an oblong or ovoid structure. This represents the vagina with its anterior and posterior walls. The structure also has a central white structure known as the vaginal stripe or V-stripe. It is important in your studies to recognize the difference between the uterus and the vagina. So let's review a transverse sweep of the pelvis. Here we see a sweep into the deeper pelvis, marked by the appearance of the oblong ovoid vagina and its V-stripe. We then see ourselves sweep out of the pelvis, identifying the uterus, its endometrial stripe, and focusing our eyes here until the sweep is complete. Here we see a longitudinal and transverse still of the trans-abdominal pelvis. Once you have positioned your probe with these images, you are all set to archive your sweeps into QPath. The ideal archiving will show each of these images centered in your screen with a slow sweep through the entire organ. Your first step when interpreting your images is to determine whether or not you have generated enough of an image to even think of making a call. In this case, you should be able to see the entire outline of the uterus and be able to identify and point out your area of interest. If your view is limited, then a call of indeterminate should be made, and steps should be taken to improve your image. Obviously, you will not be successful on every attempt. However, when faced with an indeterminate image, consider maximizing your chances by improving your acoustic window. This will include further filling of the bladder and keeping the probe close to the symphysis. Of course, one may also consider our next tool in scanning, that being a transvaginal approach. We have now tackled our first fundamental approach to bedside scanning of the pelvis. The trans-abdominal scan should be your first assessment in all female patients when scanning pelvic structures for findings of pregnancy or free fluid. When it comes to more detailed assessment of early pregnancy, we can now include the option of using a new technique, the endocavitary or transvaginal approach. The endocavitary probe is not only different in its physical form, it also incorporates some important differences in functional physics. First, this transducer comes with a higher scanning frequency, typically ranging from 5 to 8 MHz. Recalling our introduction to ultrasound physics, as the frequency of waves increase, the depth of penetration of those waves decrease. As a result, we need to be much closer to the structure being interrogated to maximize this element of physics. This will not be a problem with this application because, as you will see shortly, the transvaginal transducer will be positioned directly against the cervix and uterus, effectively eliminating this concern about depth of penetration. As you may recall, higher frequency ultrasound waves will result in better axial resolution, giving us nice images of interrogated structures and giving better distinction of structures at very close depths to one another. This is especially useful in early pregnancy, when structures being scanned are by their very nature quite small. Now is the time to mention that since the probe will be directly against the uterus, we no longer require an acoustic window. As such, for this study, we will empty the bladder prior to scanning. As you will see, we will still use the bladder as a landmark, but in this case, not only is a full bladder uncomfortable when being pressed on by an endocavitary transducer, it also makes imaging more difficult. In general, women seem to be quite thankful that they no longer need to have such a full bladder to facilitate imaging. Further inspection of the end of this transducer reveals that it has a very wide field of view. Whereas our curvilinear probes typically have fields of view of less than 90 degrees, the transvaginal probes are greater than 90 degrees. This difference in field of view allows you to easily determine which type of probe is being used when reviewing archived images. To prepare the probe, we go through a series of steps. First, on a sterile probe, we add generous amounts of ultrasound gel. Next, a sterile cover, or condom, is placed and air bubbles are pressed out from the covered tip. The presence of air will add significant artifact to your study, so this is an important step. Finally, apply an external layer of gel for lubrication and further enhancement of the minimization of air at the point of probe contact. Please note, the preferred gel in this case is muco or lubricating gel used for speculums. Ultrasound gel is rarely associated with vaginal irritation. As such, we tend to avoid it if another option is available. If the bladder is empty, the probe is prepared, then you are all set to go. In case you are wondering, our only contraindication to transvaginal scanning is recent gynecological surgery. As you can imagine, this is rarely encountered, especially when our main use is in the assessment of early pregnancy. The first move with the transvaginal transducer is going to be in the sagittal plane. We will gently introduce the transducer with our probe marker pointing up or towards the patient's anterior. We must now find our sonographic landmark, the bladder. We can see from the orientation on our screen that the relatively empty bladder will be tucked up anteriorly relative to our probe. To be sure that we find our sonographic landmark, we need to drop the probe handle to allow the probe head to move anteriorly and go find the bladder. You will see the bladder sneaks into the field of view on the marker side of the probe. To show you how this correlates with our ultrasound image orientation, we will rotate this diagram by 90 degrees. This allows us to see how things are represented on an ultrasound screen. Let's take a closer look. First, we identify our sonographic landmark, the bladder, which is a fluid-filled anechoic structure. This is not free fluid, as it is contained by a thick outer echogenic wall, the bladder wall. Immediately adjacent to the bladder is our area of interest, the solid organ density of the uterus, and more specifically its white echogenic stripe representing the middle of the uterus, the endometrial stripe. Ultimately, we will be sweeping through this structure, looking for our signs of pregnancy. Now that we have reviewed the important structures, let's review a quick test of your screen orientation. When viewing this image, which area of the screen represents the patient's anterior? Recall that our probe marker is oriented towards the patient's anterior when we use our probe in the sagittal plane. Further, the bladder is anterior and is predominantly on screen left when scanning in the sagittal plane. Where is the patient's head? In this scan, the patient's head is visualized in the far field. Take a minute to review the last few slides to be sure this orientation makes sense. Finally, where might we expect to see free fluid? The pouch of Douglas is shown here and is the first area that free fluid is most likely to accumulate, although free fluid can be seen anywhere surrounding the uterus. When performing a sagittal sweep, your hand will sweep slowly from side to side, basically in the plane of your fingers that are holding the probe. Our next move is to rotate the probe handle 90 degrees counterclockwise. This will align our probe marker on the handle towards the patient's right side. Depending on how empty the bladder is, and recall it should be pretty empty, we will again drop our hand to find the bladder. In this case, the bladder will only be seen as we aim our probe anteriorly and will be lost as we sweep posteriorly. Let's see what an image in this plane might look like. Here we see our bladder in the near field. Recall that since it is relatively empty, it'll easily collapse as you apply pressure with your probe. This image shows the bladder is being compressed by our probe, and we can identify the bladder occupies much of our near field. This is a classic finding in the coronal plane. Immediately adjacent to our landmark is the solid organ density of the uterus. Of course, we are interested in the middle of the uterus, the endometrial stripe. In this case, it is much thicker than the other images we have seen. Recall that the endometrium changes significantly during different phases of the menstrual cycle and can appear to be quite large. It will also vary in its degree of echogenicity. Now that we have reviewed the important structures, let's again review a quick test of your screen orientation. When viewing this image, which area of the screen represents the patient's right? Recall that our probe marker is oriented towards the patient's right when we use our probe in the coronal plane. Where is the patient's head? In this scan, the patient's head is visualized in the far field, similar to the sagittal image. Recall you rotated your probe counterclockwise, but did not change the near field, far field orientation of structures. And finally, where might we find free fluid? Here in the pouch of Douglas. Again, please take a minute to review the last few slides to be sure this orientation is beginning to make sense. In this coronal sweep, We again follow the plane of our fingers, resulting in an anterior, posterior motion sweeping through the entire uterus. Similar to our transabdominal sweeps, you will aim to archive full sweeps in both sagittal and coronal planes for your studies in QPath. The benefit of transvaginal scanning is that the images will nearly always be determinate, in that you can usually see the entire uterus, so therefore can make an interpretive call. So this concludes our introduction to point-of-care scanning techniques of the female pelvis. Be sure to review the next screencast in this series, where we will review the sonographic findings of early pregnancy. An additional screencast will focus on more of the clinical correlations, pearls, and pitfalls of this application, along with several examples of positive and negative findings. You can find all of these resources at WesternSono.ca.